For the anterior tooth, we always go for a 3.2 or a 3.5 implants. For canine, always going for 4 or 4.5. For posteriors, always going for a 4.5 to 5. Never give a 3.5 or a 3.8 for a canine or a molar. Canines extrinsic forces are always dominant. So you have to go in for a little a mid-range implant, that is 4.2. Not less than that, not more than that. Implant occlusion. See, in a nutshell, it's a vast topic in a nutshell. There are two types of forces in the oral cavity. One is called the vertical forces, the others are the horizontal forces. Horizontal forces are also known as eccentric forces, vertical forces are known as centric forces. So in a healthy occlusion, the vertical forces should dominate the horizontal forces. The centric forces should dominate the eccentric forces. Wherever eccentric forces are dominating, you will end up in fractures of the cusp, wear and tear of the teeth, fracture of the canines. You see most of the canines will be cut as if someone has used a burr and cut with the patient. You see, that's a sign that the patient has a dominating extrinsic force. What you have to do, build up the canine with composite. Adjust the occlusion. Adjust the occlusion. Ask the patient to bite normally. Use. If he keeps on breaking it, you have to give some composites in the occlusal surface, adjust the occlusion, and then plan the case. But if you're going to give an implant in an eccentric forces dominated person, the implant will definitely fail. It may not be a complete failure. There can be a fracture of abutment screw, or even the fracture of the implant also, or the fracture of the ceramic portion. Okay. So in an implant occlusion, how am I going to reduce this eccentric forces? Very simple. Your cuspal angulations. At times we go and sit in the lab as prosthodontists. We sit in there. We design the cuspal angulations. We never go for very steep cusp. Maximum 20 degrees. 10 to 20 degrees is more than enough. Below that is going to be a monoplane occlusion. It will look like atreided teeth. Definitely it should not be atreided. That is very much a thriving ground for eccentric forces. You have to give at least 20 to 25 degrees. And never go in a normal occlusion. We can go in for an FPD, it can go up to 40 degrees. But for an implant, cuspal inclination should be 20. And whatever the forces, all the forces should go only through the long axis of the implant only. So that is where your planning stands. So how these occlusal forces can dissipate? Wider implants posteriorly, as we discussed before. Avoid cantilevers and go for ideal prosthetic materials. For long span bridges, generally we even go for composites. There's something called the Trident has come out with I think high impact polymer composites. But most of the cases we go in for PFR. So mesial-distal and buccolingual cantilevers has to be observed. Never go beyond 3 mm. You have an implant, it should not extend beyond 3 mm. If it's going to extend 3 mm, it's going to be a seesaw effect. Your abutment is going to be tortured. Your abutment screw will fracture. Never go for this one. This is one case we saw, like it's unacceptable processes. So now we have a semi-digital protocol. Again, a failure case. A person has placed an implant. The patient in this case was referred to me by a physician. They have placed the implant from buccal to lingual. 3 minutes. So you can see the implant is perforating the lingual cortex here, and it is also compressing the nerve. So what can be done? I have to remove the implant. So we opened up flap, we slowly removed the implant. We gave grafting with sticky bone and PRF. We gave a pilot drill guide, planned virtually, guided surgery. We went only for the pilot drill, and we opened up the flap to see the quality of the bone. This is the quality of the bone. This is after 6 months. The quality of the bone after grafting. Then we made the final osteotomy. We placed a osteo PS3. Another 3 months. We went for stage 2. Look at the emergence. Look at the soft tissue emergence. Look at the position with respect to the ipsial nerve. This is a screw retain process. Abutment and process in one single component. This is the process, and this is where we started. It is all the same location. All three have been done in the same location. This is the planning and this is the final process. Can you see the amount of bone here in the lingual aspect? So this shows that accuracy is much more in a hybrid protocol. And one case, last case, like it's a fully guided protocol. Look at this case. For anyone placing implant, this will be a paradise. Look at the gingiva, emergence, everything is so good. But when we went for a CPCD, this is what we found. The canal is right below the edentulous area. Even I will not have the guts to open up and place an implant directly. Definitely not. So we documented this case. Patient is from an NRI, another from US. Even a small injection, they'll give reaction like it is 10 times or whatever it is. So we have to handle them very softly, very delicately. So we decided to go in for a fully guided protocol. We took an interval scan, and this is the software ExoCAD. Usually works in 3 stages. We merged the CPCT and interval scan, and we planned the point of entry in the software, and finally the implant dimension, everything has been planned. So once it's done, we design the surgical guide, and even we design the processes because we know where my implant is going to come. 3D printing done. So this is the surgical guide, and this is the fully guided protocol. The first thing is, what we do is, we stabilize the guide. We use a soft tissue punch. The entire process, the surgical process, processing process, everything will be through this guide. You can see the soft tissue punch, the soft tissue there. It should be eliminated on one single piece. This is your hard tissue punch. This is going to indicate my point of entry. See, I will not be able to see the surgical side. All I have to do is touch and feel concept. So initial preparations will be depth. We planned a 4.5 by 12 mm, but we started with the 8 mm drill. The 8 mm, which is followed by 10 mm and then 12 mm. Why I can't go? I could have gone in for a 12 mm because my irrigation should go to the depth. If it is guide, I had to make sure my irrigation has to do it very, very slowly because the entire during drilling, the entire surgical area will be closed. Lots of heat generation is possible when doing guided implant. So all my speed has to be reduced, torque increased, as well as my irrigation should be doubled. And once I reach the depth, then gradually I increase the width. I go for 3.5. And finally I use a crustal preparation. Some implants companies, they suggest a crustal preparation. And then I connect the implant to the mount. So first initially I hand tighten it, but the final I always check it out with a torque wrench. It's a very young patient. The torque was so amazing. We got 45 newtons. See that? So very ideal for immediate loading. So once it's done, we remove the mount and the guide. Yes, we remove the mount and the guide. This is the surgical field. After controlling hemostasis, this is what? No suturing, nothing. We connected the abutments and then we gave the crown. This is the immediate post-op. This is how the patient walked in and this is how the patient walked out. We were able to finish the entire process within 1 hour. 1 hour. We call this a tooth in another concept. So this is a take-home message. Always go for patient selection. Check the patient whether he will be able to maintain or what is his requirements. His requirements are favorable or acceptable. Always go for a prosthetic planning. Meticulous hard and soft tissue evaluation is mandatory considering the biotypes. 3-dimensional placement of implants, soft tissue management, any grafting if needed. Impression techniques, whether it can be mostly it's a close straight, or you can even going for a digital impressions available today. And always give the processes in implant protected occlusion. Thank you very much for your patience. This is my practice. I'm a training center. So that's my digital ID. Thank you very much. Thank you for the opportunity. Thanks, Rajshekhar sir, madam. Thanks a lot for all your support. Thank you for this opportunity.
Thank you so much, sir, for that insightful session. Any questions from the audience? I request Dr. Prabhu, sir.
Thank you, sir, for your wonderful presentation. Actually, it's very difficult to have single tooth replacements with implants. Very difficult to manage the aesthetics and the function. Full mouth, it's better because we can plan and alter the position of implants based on our requirements and bone conditions, but very difficult for a single tooth. Still we are struggling over 25 years. Very difficult to manage single tooth, especially anteriors. It's tricky to place those implants in the aesthetic zone. Any questions?
Yes.
So that you have mentioned the crown and the abutment in a single frame for an anterior.
Yes.
Is there any protocol that is decided to do so, or you just take an impression and give it to the lab will take care of it?
Two things you have to evaluate. First thing is the vertical restorative space you have to evaluate, number one. Number two is you are supposed to make an implant level impression. So once you made an implant level impression, the lab will be very clear of where the implant platform is going to be. Then we have an abutment called as the tie base, where the base will be of titanium, the upper one will be plastic. So you can add bats and you can do the casting or you can do the milling, whatever it is. So that's the lab protocol. So these from your side you have to go for only two things. One is the vertical space available, you have to tell the lab, and second thing is implant level impression. That's it.
And you have mentioned that there are ideal dimensions that have to be maintained for a canine or for a molars.
Yes, yes, yes.
What if the patient shows up to the practice with only 6 mm of bone available, buccolingually in the mandibular posterior region? Like if I go for 5 mm of implant dimension, the bone availability will not be ideal. So what should I do? Is there any protocol that you tell us? I mean the grafting protocols that we have to maintain.
See, for example, you are asking if whether it's available a 5 mm. Should I
It's
go in for a 5 mm or I can go in for a little narrower implant? Okay, fine. In anterior cases, we find when the bone is abundant, you can still, what I do is I plan my implant in such a way I leave only 2 to 2.5 mm of labial bone and soft tissue. Labial bone and then it will be soft tissue, irrespective of the size. You understand? Okay. So, but since with I have to give an emergence also. When I am more wider, it is very difficult to give the soft tissue emergence. So always I go for the mid range. The canine almost 4 to 4.2 or 4.2. Posteriors 4.5 to 5. So moreover posteriors, vertical forces are going to dominate. So always go for wider implants. And for anteriors, more narrower, not too narrow, don't go for too narrow implants. The narrower the implants, the better soft tissue emergence will be there. So you have to consider plan accordingly.
Sir, can you highlight on immediate implant placement versus delayed? When we will choose for immediate and delayed, and some insights on socket shielding for immediate implant placements.
So again, we have to first evaluate the tooth, reason why we have to extract the tooth. Whether the tooth is fractured, whether there is any kind of bone defects, or when there is going to be any pathology, the effects. At times when kind of any fracture, the root and the bone is very safe, then you can very slowly eliminate the root beginnings of a periodome or with a piezo, and then you can place an implant. When you are going for a socket, always place the implant in the palatal and the distal aspect. So with the curvature of your root curvature, you will be able to purchase more of bone. Do you understand that? So always, so more palatal you go, the more of emergence you will be able to deliver. And socket shield.
Say it's into socket.
Socket shield. What is socket shield is, we at times when the bone is very thin, soft tissue is thin, what happens is, what we can do is, we can leave a thin sheet of root. We trim the root inside. There are certain specialist burrs available. We trim the root and leave a small portion of the root inside, only the labial aspect, and the remaining edentulous space, the empty space, we place the implant. Again, for this case, you have to be very careful whether there is not going to be any kind of anaerobes, because if the anaerobes dominate the periodontal ligaments, any gingival issues, you take a swab or you take this, the anaerobes will be dominating. So only thing is, you have to check out for anaerobes, because anaerobes are there, it's going to hit your implants. Once you find it's very free of infection, you can leave a thin plate of the root in the labial aspect and then place the implant in the palatal aspect. Still successful osseointegration to happen. We call this a socket shield technique.
So I have one question.
Yes.
As you mentioned on socket shield technique, there are types of shields that we do, like C-shaped or leaving it only in the mesial and distal aspects. So which type of shield is better, sir, for achieving the aesthetics? Because the buccal plate plays a major role in bone resorption and the vascular supply in the anterior region. So if I make like a full C rather than a partial C, will it be enough for me to have a better aesthetics in the buccal area?
Okay. See, we have to evaluate how much of bone, why you are going for the socket shield. Really the bone is very thin. At times what happens is, bone will be thin in the apex, but ample bone will be placed in the crescent. In those cases, there is no need to extend your shield to the base. You can stop your shield in the midway. That is only from the mid portion of the socket to the apex when the root portion fragment is remaining. That's absolutely more than enough. But if the bone is thin through and through the labial plate, you may have to leave the entire labial surface of the root inside and bring the implant more palatally. So this you have to decide with your CBCT. This is how you decide it.